Good morning and good afternoon, everyone. This is Carla Gagne. I am with Exosome Diagnostics and the organizer for this webinar with Dr. Liam Hurley. We are very pleased to have you join us today. I wanted to give a quick introduction to Dr. Hurley and also a few housekeeping details. First, all participants will be in listen-only mode, but you will have an opportunity to ask questions. The way to ask questions is by looking at your control panel and write your question in the questions box or the chat box. I will be monitoring those throughout the program. You can ask those at any time, or you can wait until the end of the program to enter your questions, and I will provide those to Dr. Hurley. So as an introduction, Dr. Hurley is a urologist with the Northeast Urologic Surgery in North Andover, Haverhill, Massachusetts, and Salem, New Hampshire. Dr. Hurley holds hospital privileges at Tufts, New England Medical Center, and Lahey Clinic. Dr. Hurley is also Assistant Clinical Professor of Boston University and Tufts. And at this point, I'd like to hand the controls over to Dr. Hurley and welcome him. Thank you.
Thanks, Carla. Hello, everyone out there, who's ever out there. I just spent the entire morning doing telemeds, as I've been doing for the last 6 to 8 weeks. And frankly, I'm tired of telemeds. And I'm hoping that our office can start to open, but our governor, as of yesterday, has just started phase 1, of which there's going to be 4 phases, and we're way behind the other states, including, I think, New York now. So the worst states, New York, New Jersey, and Mass, are still suffering from some of this COVID. So I wanted to, as I do a lot of work with Exosome and do a lot of ordering with Exosome, I thought I'd try to do something different besides the telemeds. But I just realized I have a slide deck in front of me and I can't see the participants. So I guess it's much like a telemed of academics. Anyways, this is a relatively new test I'd like to get into, and we'll have questions at the end. The title of this is the prostate test. They've had a couple of webinars already, but I wanted to somewhat address the COVID issue, particularly here in Mass, because we are still with a high incidence of COVID, and we can't bring people to the office. We are having trouble getting non-urgent patients into the office. So what are we doing, trying to figure out who needs a biopsy and who we need to progress with on trying to diagnose a prostate cancer and who may need to be treated sooner than later? And that's been an issue in this state. So my title is The Solution to Address Fear of the Prostate Biopsy Decision. How do we figure out who we need to bring in, and how can we expedite that and make it easier if we can't bring patients in? So I want to get into that, and I'm going to advance the slide. And Carla, please tell me if this is not working. But the agenda today is the clinical need. And the reason I put that up is because of this COVID fear. We're trying to get patients diagnosed and treated correctly, appropriately, and expedited it in the best fashion possible, but that has been a challenge, as I'm sure it's been for most of you urologists out there, as to how to proceed with this. We're going to also talk about exosomes. I have found until I started using this test, I knew nothing about exosomes, so I want to give you a brief synopsis of what exosomes are, because it is a hot topic now that Dr. Skog brought into the forefront from his papers in 2008. Exosome DX risk assessment, how we use this test, some of the validation data, which I kind of trimmed down a bit because I thought I don't want to bog you down with boring numbers, but there are 2 papers that have really brought this test to the forefront. I think the most important aspect of this talk will be the clinical utility study, which was put together by Chesapeake Bay Urology down in Maryland with one of the authors, Dr. Tutrone, who I actually trained with up here in Boston many years ago. Great paper. I'd like to go over it, go over some of the numbers, because I think it's important. Recent milestones with Exosome, going over a few clinical cases that you might be able to use this test for, and then a summary. Now, no talk starts without this picture. So I know Tom Brady just got traded, but in the last 10 to 15 years, we've had 12 championships, 6 football, 4 baseball. Yeah, I know the Red Sox, Patriots cheat. I don't want to hear that. And then there was 1 Celtic and 1 Bruin. So I had to put this up. These are the Sports Illustrated pictures of our championships. Not bad for a small town in New England. So let's address what I think is a significant clinical need at the macro level. Okay, this is towards a nationwide audience, but in theory, you know, when I give these talks, you know, until recently, you know, there was probably 1.2, 1.3 million prostate biopsies a year. And if you look at the prevalence of prostate cancer being about 200,000 cases, right, and about 30,000 deaths, you know, we're taught that out of that 1.3, 1.2 million, you know, if you take away the 200,000 cases of prostate cancer, you're left with like a million negative biopsies, of which out of that, there's probably 25% false negatives, which is another topic that we can talk about. But when you look at those 200,000 prostate cancers that are diagnosed, only about 30% are high grade. So you're left with not only a million negative biopsies, but out of the positive biopsies, maybe 2/3 of those are low grade. So 65 to 75% of these biopsies are resulting in benign and low grade disease. And that is a burden, right? And we've been criticized for, you know, our screening of prostate cancer. I still think we should screen. That's not my point here, but I do think we've over treated a lot of these prostate cancers, and as a result, you know, our screening has gone down. Now I think we're up to a C+ grade, and we're looking at people from 50 to 69, but it was not even recommended at one point. Now I certainly think screening is appropriate, and I think we need to screen appropriately so that we are not having to treat aggressively, but, you know, low-grade disease. And that's the whole topic of this talk today, because the complications, and I don't know, I'm sure every area is different, but the prostate biopsy complications in certain areas, particularly with sepsis, has risen dramatically. This is only 1.5% on this slide, but in my area, it's up to 3%. And you know, we could certainly do rectal swabs, which my patients don't appreciate, and it only looks at basically quinolone resistance, but you know, the side effect profile of biopsies has risen tremendously. You know, hematospermia can be bothersome for some patients because it's nerve-wracking, but I think pain, fever, hospitalization, and sexual dysfunction can be an issue when we do too many biopsies. And of course, the overtreatment of Gleason 6 cancer. Next slide. So this is going to address a significant clinical need in a micro level. This is just looking at 3 patients, okay? All 3 about the same age, PSA levels about the same. And if you look at these, you'd say to yourself, oh, right, which one of these may need to proceed to biopsy versus being able to be deferred? There's no really strong way of knowing. And because of the poor specificity of PSA, it's very difficult to decide which way to go. With EXOSOME and a slide towards the end of this presentation, we will evaluate how EXOSOME might be able to distinguish which one of these patients needs to be biopsied and which one doesn't. So change is underway. I like this particular slide because, you know, when I got out of Lahey Clinic, you know, it was a molecular diagnosis. You know, truss biopsy was really the way to go. I'm old enough to remember doing biopsies in the operating room, putting a needle on my finger rectally and trying to find biopsies, and half the time getting my finger as well as the glove in that biopsy. Molecular biopsies have come a long ways. You know, we obviously have, you know, new tests to actually look at which negative biopsy might potentially have cancer that was just missed on the biopsy by epigenetics. We have biopsy post positive that help determine who may need to be treated because it's more aggressive than we think, with Oncotype and Decipher and Polaris, those sort of tests. We went into the heterogeneity of issue, which means, you know, for the most part, we sometimes get the cancers that we are biopsying for, which makes up less than 1% of the total tissue. There is a heterogeneity issue in that the cancers are different within even the same prostate gland, with different markers in different parts of the prostate. And there's a lack of sample access, as I stated. But we've now come to the point where tissue-based diagnosis has gone to liquid biopsy. And I want to get into that because I think it's a new approach that people haven't looked at. And it's very easy. And again, Dr. Skog has looked at this in the past with and come up with the EXOSOME test. These liquid biopsies are less invasive. They're easier to access and sample if you're looking at particularly urine, as in this test. The cost is lower because it's only a liquid biopsy. There's real-time insights. We'll get into the exosome being a dynamic real-time tracker of what's going on in those prostate cancer cells. You can get to the clinical trial and quicker to market with these liquid biopsies, and as a lower cost. This makes it a very exciting and enthusiastic approach to companies who want to deal with this. It does support treatment stratification and monitoring. Although this particular test, exosome, is looking at diagnosing prostate cancer, exosomes are also being looked at for potentially even biochemical recurrences, and even potentially looking at how treatment options are progressing with that prostate cancer by looking at exosomes. Quite interesting. So we try to get the right treatment to the right patient at the most appropriate time. And right now, the exosome is the first liquid biopsy test that's been approved. Now, liquid biopsy gold rush, I did state there is liquid biopsy test out there, and I am looking at the exosomes, which is the third here, but blood is also being looked at with tumors, circulating tumor cells, cell-free DNA is being looked at, for those of you out there who have read some of these papers, but the exosomes will always outperform the CTC and the cell-free DNA. But those are what are out there. So when we look at exosomes, what exactly is an exosome? So basically, we look at exosomes as a double lipid layer. It's a extracellular vesicle that comes from the endosomal compartment, all right? And it's used as a cellular communicator, all right? And it's really looks at the real time into a patient's cancer. It allows us to not only predict and rule out high-grade cancer or disease, prostate cancer, but also how to monitor things such as I stated, like biochemical or recurrence. But it is secreted by all living cells, okay, into all biofluids. So although we are looking at a urine test today for prostate, these exosomes can be found in urine, blood, CSF, and I believe even semen. And what's also interesting, because I've talked to Johan Skog about this, is that they are using this not just for prostate cancer or any cancers, okay? They are looking at this for other diseases such as inflammatory or neurodegenerative diseases. They are using exosomes, which I thought was very interesting, looking at Alzheimer's and chronic traumatic encephalopathies. Some of these, these post-sports syndrome head injuries. It would be great to try to figure out if, your exosome potential goes up with head injuries during sports, who you can predict might have problems down the road. So I do think exosomes are very real-time informative process that's looking at the live processes within a cell. The cell-free DNA only represents necrotic or dying process of a cell. The exosomes in this case are the byproduct of the living processes, all right? And they, as I can state here, is they're important in inducing angiogenesis, stimulating cell tumor growth, blunting immune responses, facilitating intracellular communication. Each one of these cells spits out almost 20,000 messages per day, okay? And when you look at the next slide, this is what it's spitting out. These exosomes can contain numerous RNA-type products, even the non-coding RNAs that are being looked at by numerous other companies, but it also has proteins, it has DNA, and these are pretty stable, all right? These are very stable within the exosomes because they're living and they're covered by this double lipid layer. And they can state at that point what the native configuration of the cell of origin, which in this case that we're looking at today is prostate cancer. So when you look at these exosomes, they are, again, a treasure trove of RNA, DNA, and proteins, all right? They're like a cellular trunk tweet, all right? I had to throw that in there. And again, there's 10,000 to 20,000 cells per day that are released by all living cells from these normal cells, as well as early and late stages of disease, in this case, prostate cancer. And again, they are involved with intracellular communication. And again, they can be involved with any biofluid. And in this case, we're looking at the urine. All right, and in this case, with the tweets, it's kind of the RNA in this case is the cell language versus the Twitter message, and instead of characters, we have RNA sequences, and instead of mistyping these tweets, we have RNA mutations. So it's kind of a cute way of looking at this. And again, these exosomes are produced by the eukaryote and prokaryote cells. You know, they were initially found by immature RBCs, but now are seen in numerous types of cells and play a role in the health and disease. I'm so sorry. But for that 10 or 20,000 messages that are popping out of the cells, whether normal or prostatic cells, look at the size of the exosome. It's much the same size as a virus. It is extremely small when you compare it to what a cell size is, all right? They're smaller than bacteria, they're smaller than platelets, yet they get the job done having within that virus-sized cell, DNA, RNA, and protein, okay? So one of the reasons it took so long to get this on board since 2008 was they were so small, we didn't appreciate the information that were placed within these small cells. So the power of exosomes in our clinical diagnostics is now enabling us to detect diseases earlier, in this case prostate cancer, and in a real-time biologic snapshot about, you know, what drives the individual patient's condition in response to therapy. And again, I want to emphasize that although we are using exosomes in this particular talk for diagnosis, we are also looking at it for treatment down the road when there's a recurrence, or we are treating it successfully with other methods that can be followed by exosomes. So I do think this is exciting. And it does overcome the tissue heterogeneity of biopsies, because this is a cell that contains the entire spectrum of proteins, DNA, and RNA from that particular cancer. So exosomes have become particularly a fast, rapidly growing field, all right? And initially, you know, DNA sequencing publications, as you can see here, started in the 80s and 90s, and really were the majority of publications until, again, Johan Skog from Sweden came up with a paper in Nature Cellular Biology that started examining exosomes. And as you can see, since 2008, the amount of exosome publications has started to dramatically increase as the DNA sequencing has gone down. Basically, the more information we are learning, we are now progressing to smaller products of information that is helping us with diagnosing and treating patients. So what makes the exosome, in this case, the ExoSomeDx prostate test unique? Well, it excludes PSA from the analytical algorithm. I'm not a fond lover of the 4K only because the PSA specificity kind of is not that good. And when you split PSA into total PSA, free PSA, and TAC PSA, and I believe human chylochrine 2 PSA, you're basically taking a test that's not already specific and just breaking it down into its components of PSA and making it potentially a better test, which I do agree with, but still it's a PSA test. This exosome targets the prostate cancer specific biomarkers, which is PCA3, ERG, and SPDEF, okay? It doesn't require an MD or a nurse to provide any patient info. As you'll see in this talk, this is a standalone test. It does not need standard of care parameters to put this test on a piece of paper to give you a score. It doesn't require a digital rectal exam prior to urine collection. Now, I found this a little complicating as a urologist because by the time I figured out I wanted to use this test, I'd already done a digital rectal exam. So you have to, once you get used to this test, you have to incorporate it into your office practice in the correct fashion, either knowing what you're going to need to use and getting the urine before you do the exam, or just having them come back to give you a urine exam later. And in fact, I will get into that. I am now sending these tests to patients at home because we can't get them into the office, and I'll get into that later. It's a non-invasive, simple urine test, so it's very easy to do, particularly if you don't need a digital rectal exam. So I do think at some point this test may be very appropriate to some of our primary care colleagues, family practice colleagues who actually don't do digital rectal exams. And I do think the exosome may be utilized at this point for very specific indications of men over the age of 50 with a PSA of 2 to 10, which is that gray area that we are sometimes considering for prostate cancers. So how do you, I put the slide in too, because when people start talking about how you collect this, it can be a little confusing. There is a proprietary ultrafiltration method via membrane affinity that is used to do this test. And as you can see, exosomes come on the left side here, not just from your prostate, but they can come from your bladder and your kidney. Okay, so you need to get the first 15 cc's, okay, into this container to the right here to get that prostate exosome. Otherwise, you can get other exosomes from other parts of the GU system, which I think in the future we will probably also be using for different cancers. But at this point, we're using the 15 cc's. You need to wait an hour between urinating to get that 15 cc's, okay? But I want you to be aware of this product here, because I've had a number of patients. You got to put, they have to put their penis in the wider area of this contraption to the right versus the smaller area. Never assume you know what a patient's going to do with this, and then you need to have them place that smaller spout over the toilet, okay, not towards their body and shoes, because once that 15 cc's goes into that container, there's an overflow, and if you don't have it over the toilet, it's going to go over their shoes, okay? So they're going to be upset with you. So I'm just giving you a heads up as to what not to go through that I have gone through. So the exosome workflow, how does this work? Well, it's pretty easy. We do that 15 cc sample, as I just suggested on our last slide. It goes to the lab. There's a patented exosomal RNA extraction. It gets to get this PCA3, SPDEF, and ERG out. Okay, that's what we call the epi-testing. It's a multivariate algorithmic analysis of RT-PCR, reverse transcriptase, and it's analyzed. And what I do like about this test is it does give you a score, okay? It gives you a score of below 15.6 is negative, and above 15.6, which we'll get into, is considered positive. There are some tests out there that make it somewhat complicating because, again, I don't want to pick on 4K, but it doesn't have a defined cut point to guide urologists to defer biopsy. As such, I think these biopsy numbers can change depending on the individual urologist and their interpretation of tests that don't have a cut point. So I think it makes it difficult to rely on tests that don't have a cut point. And I'm at the same point, I know that cut points are not perfect, but I do think they help urologists. So in this cut point with the exosome, the test score ranges from 0 to 100, and it is separate of care factors that we see that we use, you know, to help assess men's risk for high-grade prostate cancer, whether it's age, whether it's ethnicity, whether it's family history. That all helps, but this test is a standalone test, okay? And when this cut point is looked at, all right, the below 15.6, and I do think, although I am talking about not missing cancers, I do think the major strength of this test is the negative predictive value of 91.3%, because we are trying to avoid biopsying people. That has been, I think, you know, one of the legitimate concerns of overscreening and over treating, okay? So I do think below the 15.6, the negative predictive value is 91%, and the sensitivity is 92%. So anything above 15.6, the majority of cancers, high-grade cancers, are seen, okay? Now, there's also a lot of non-high-grade cancers above that 15.6. So the specificity and a positive predictive value are only in the 30s, 35, 40, but you are going to find a majority of these high-grade cancers above the 15.6, and I think that's an important concept to look at. Now, exosomes, prostate broad spectrum acceptance has gone a long ways. You know, it's funny, at Lahey Clinic, when I graduated, NCCN guidelines were never even looked at. Now everything's NCCN guidelines, and in May of this past year, we are now including exosome DX test in the early detection of prostate cancer for both initial and prior negative biopsy patients. And we'll get into the prior negative also. There's been a growing major private and public coverage decision. We have positive LCD, which is more important in some states than others. We have a lot of Medicaid contracts. We have the Blues covering this. I'm not able to discuss this, but in my state of Massachusetts, we have 3 new carriers coming on board that I'm hoping will change or make it easier for me to order these tests. As you know, commercial carriers in different states, there's a lot of them, and there's a lot of them in my states, and it requires a lot of legwork to get them approved. Once Medicare approves these, most of the time, a year or 2 down the road, the commercial carriers come on board. EXOSOME's done a very good job at getting the VA healthcare system, and there's just, as you know, every system in every state is different, so they've gotten a 10-year GSA award, and we have additional local and regional plans in progress. For those of you in New York, and I don't know if anybody in New York is listening today, but trying to pass anything in the state of New York, and Dave Abala gave this talk, a few months ago, it's extremely difficult to get this approved. It could be that the New York urologists are just not as wicked smart as the Massachusetts urologists, and that's why they have this. I'm just kidding. I'm just kidding. I hope Dave's listening. But they do have a very stringent credentialing process, and it does take a lot longer in your particular state to get these things approved. All right. Exosome data. I did promise you we were going to look at some of the validating trials of ExoSomeDx, but I just want to first put this one up because there's 2 validating trials I'll get into, but there's been at this point, over 5,000 patients from over 30 academic community urology clinics in the US that have done peer-reviewed publications on this particular test. And the 2 most prevalent and most important are these 2 prospective clinical validation studies, one in JAMA of Oncology in July of 2016 by Dr. McCarran, which demonstrated a 27% reduction in necessary prostate biopsies, as well as the EXOSOME test in the European Urology Journal. Now, I don't know who gets this journal, but I do, and I think they have a great journal that not a lot of people read, and I do like their clinical criteria for some of their disease processes that come out. I think it's a great journal, and this also looked at discriminating between high-grade Gleason score of greater than 7 versus the low less than 6 Gleason scores. As an aside, I just want to, as I was doing some of these lectures, there is a new standardized urology pathology score system that's out there now, and it's called the International Society of Urologic Pathology. I don't know how many people out there are aware that our Gleason grade scores have been sort of incorporated into a new scoring system that's an international society system. And basically, the International Society system of greater than 1 is now Gleason 3+3, greater than 2, 3+4, greater than 3, 4+3, greater than 4, old system 4+4, 3+5, or 5+3, and then greater than 5 is greater than a Gleason score of 9 in the Gleason score system. I just want you to be aware that when you see some of these tests that are now out there and they say, the ExoSomeDx is discriminating greater than or less than a score of 2, which is basically greater than 7, okay, in the old Gleason scores. So these 2 particular validation trials were very important and got ExoSomeDx on the road to discovery and validation. And, in a nutshell, the JAMA article to the left there, looked at a cohort of over 1,500 patients with a strict criteria of age greater than 50 and a PSA of 2 to 10, a gray area, as we suggested. And it looked at the predictive value, negative predictive value, which is, as I again said, was 92%. And they actually discriminated between an intended to use population of about 519 patients in the validation cohort after the training cohort, which is a signature kind of leading up to a validation trial, versus an extended study which looked at PSAs that are somewhat 2 to 20 in some patients and had repeat biopsies. So this particular trial that I'm looking at now is really the intended use population of 2 to 10, okay? And as a number 3 here suggests, clinical studies evaluating test performances in populations with high median PSA and low prevalence of high-grade prostate cancer are an easier cohort, all right, and boost statistics like negative predictive value, okay? Obviously, if other tests are incorporating wider PSA ranges and the disease prevalence changes, and they're using repeat biopsies that are already somewhat ruled out, maybe potentially bad cancers, your statistics are going to look a lot better. I mean, if you're going to include patients with PSAs of 30 or 35, they're going to have prostate cancer, right? So this was strict criteria in this particular trial with EXOSOME, which didn't do this and used very narrow range PSAs of 2 to 10. And again, this first trial, and I think I sort of got into this, were all initial biopsy patients, all right? They had a training trial that went into a validation trial, and that was over 500 patients. And again, the inclusion was 2 to 10, greater than 50 of age, okay? And that was the only part of this that was looked at. There was no other criteria, very strict. And when you look at the exosome accuracy, you know, we always talk about this area under the curve, and some of the competing tests had area under the curves up to 90%, which it looks great, all right? But if it's that great, then there's something going on, because it shouldn't be that good. When we look at these area under the curves, this is basically a balance between the sensitivity and specificity of a test. And when you look at Exosome DX, you can see that the area under the curve was 0.71, and it was more accurate than the standard of care here, which is 0.63. Again, you know, age, ethnicity, family history, and it was even better than the, you know, the prevention trial, whether the U.S. trial or the European trial, which is only 0.62 and 0.58. And of course, again, the specificity of PSA is not that good, and the area under the curve on that was only 0.55. So the exosome outperformed the PSA in the clinical risk calculators for high-grade prostate cancer. All right, and it was independent of the standard of care, which I think is an important topic. It's not to say that we as urologists are not going to use standard of care in addition when we make a decision for either biopsying someone or not. But and I'll get into that with the clinical utility trial, but it is important to have, I think, a standalone test, and you can see that here. I threw this slide in only because this looks at basically the area under the curve for exosome plus standard of care, which was the green here to the right, versus just exosome versus standard of care versus PSA. And as you can see here, exosome and standard of care is about the same as exosome, basically suggesting that we don't need standard of care for area under the curve for this exosome test. It is a standalone test. Now, again, we kind of looked at the validation trial here in the JAMA article, McCarran, and again, the sensitivity, okay, was 92%, meaning anything above that 15.6, the majority of those cancers, okay, you're going to find a majority of those high-grade cancers above that cutoff point. The negative predictive value is 91.3%, okay? And what's interesting in this particular trial is the majority of false negatives, okay? And the percentage of finding high-grade cancers below 15.6, okay, is about 8 or 9%, okay? In this particular validation trial, false negatives were found in 12 cases, of which 9 of those cases had Gleason score 3+4 with less than 3 positive cores, okay? So if you include actually 3+4 as being a non-aggressive cancer with the Gleason 6s, you are now looking at only 3 cases of Gleason 4+3 being missed, and the negative predictive value can go up to 97%. Okay, so if you actually include Gleason 6s with Gleason 3+4s, the negative predictive value of this test actually goes up to 97%. So I think that's important, because a lot of us are considering 3+4s as being non-aggressive at this point. So what about these validation trials? We sort of went into it. You know, 100% of the patients included in this particular validation trial, whether it's the JAMA oncology with McCarran or the European urology, again, it was strict criteria using only over 50 years of age and PSA 2 to 10. All right, the negative predictive value was excellent, anywhere from 92% to 97% if you included the 3+4, and you know, prostate cancer prevalence was high. Remember, you know, if we biopsy the average patient over 50, we probably get a 30% incidence. But if patients are coming to us with higher PSAs and coming out of a urology office, you know, there's a lot of studies out there that suggest that this 30% is actually probably a lot higher. All right, you know, again, while most studies have showed 30%, there are trials out there like the PROMISE trial that showed that transrectal ultrasound biopsy sensitivity was close to the 48%. And if you used, a template biopsy, you can probably get up to 53%. All right. So when you look at transrectal ultrasound, only getting 1% of your prostate tissue, and you're potentially missing over maybe about 50% of high-grade prostate cancers. This prevalence of high-grade prostate cancers in a population that we are seeing as urologists could be as close to 50 or 60%, and not just 39% that we see on standard biopsy cohorts. Okay, so I think you need to keep that in mind when you look at studies and how you're comparing studies. Now, what about prior biopsies? Because I stated I would look into this. Well, that was a second part of that validation trial with the JAMA article, McCarran, and this basically looked at a population of men that were very similar to the initial biopsy patients, and they used the cutoff of 15.6 again, okay? And when they looked at the area under the curve, once again, it was very, very similar. Remember, this has already had one biopsy. The accuracy, the AUC is 0.66 compared to the prevention trial of 0.61 compared to PSA of 0.54, very similar to the initial biopsy. This is on repeat biopsy. And again, the negative predictive value is close to 92%, which is very similar to the initial biopsy. But what I do like about this particular paper, and was not presented in past webinars, is the fact that if you do a biopsy on a patient, okay, and it's negative, all right, I do think, you've sort of ruled out who might already, you sort of ruled out a high-grade prostate cancer already, and I'm not quite sure you always need to use the 15.6 on a repeat biopsy patient, because if you do use the 15.6 and they already have had a prior negative biopsy, the negative predictive value using the 15.6 is again 92% negative predictive value, and 23% of biopsies are avoided. But if you look at, all right, maybe a slightly higher EPI score, 29.5, okay, not 15.6. Remember, some of the validation trials with some of the other tests included patients who had initial prior negative biopsies, and that's going to inflate your numbers. If you have somewhat ruled out that they probably have a big, bad high-grade cancer, I think you can raise that EPI score to close to 29.5 or 30, and your negative predictive value goes up to 94%, and you can avoid up to 56% of biopsies. All right. What's interesting about, and let me just show you that in a different, here's just a different aspect of looking at this. Again, if you look at the pathology here, you can see benign 1, 2, 3. This is the new international standard, and we're looking at GG2, which is basically a 7 or higher. When you look at cut points of 15.6, you can see that you're going to avoid 23% of biopsies, but if you use a 30, okay, you're going to avoid up to 56% of biopsies. I think this is important because with this particular trial, when we looked at scores of EPI, basically when you go from 0 EPI score to 60, it's somewhat binary, meaning you're probably going to find 30% of cancers at a score of 30, 40% of high-grade cancers at 40, 50, 60, etc. So I think once you get to 30 and it's a 30% incidence of high-grade cancers, that's basically where the majority of cancers or biopsies are going to find cancers if we were to just biopsy the general population. So I do think I like this particular test because as you will see once we get into the clinical trials, which was the Chesapeake Bay, I do think you're going to see that there's going to be some patients who have a low EPI score who were still considered to have a biopsy versus a higher EPI score who didn't have a biopsy. So there's still some standard of care issues that are used to make a decision on who gets a biopsy or not, and not just using the exosome score. So having said that, what about this clinical utility trial that I am talking about? And I got to tell you, for those of you out there who have done webinars or done studies or have even spoken about this, doing a clinical utility trial is extremely difficult to do. It takes a lot of manpower, it takes a lot of patience, it takes a lot of resources to get these things performed. And this is Chesapeake Bay, again with my buddy down there, it's the only prospective prostate cancer biomarker utility study with a blinded control arm. All right, and so this was investigating ExoSOME DX's clinical utility. All right, it was a multi-center study. It had 72 urologists, 24 clinical sites, over 1,000 patients. You know, it's interesting because Chesapeake Bay down there is a huge organization, just got taken over by venture capitalists. They got a ton of urologists out there in a ton of different areas, which is I'm just not used to, because it's like we have town meetings here of urologists where we have 5 or 6, and that's considered a big group. And again, these inclusion criteria are men, greater than 50 years of age, PSAs 2 to 10, all right, and they were all. All these patients, and I want you to remember this, were already considered for a biopsy, okay? And when I get into this trial, you'll see that 60% of the patients in the control arm did not follow this recommendation, all right? And I just want you to remember that the objectives of this particular trial were ExoSomeDx Prostate test reducing unnecessary biopsies, ExoSomeDx Prostate test increasing the compliance with the biopsy recommendations, and does the ExoSomeDx prostate test influence shared decision-making regarding prostates, all right? And I want you to remember that I love this test because it highlights the importance of a control arm in this particular biomarker utility trial, because it will get into how practice patterns may confound or influence study outcomes, okay? And that's very hard to do in a lot of the competing trials that we're looking at. Using their tests in a utility trial really didn't have a blinded control arm, and that's extremely important. It's also extremely hard to do, all right? So the key outcome is you'll see that we detected 30% more high-grade prostate cancers versus standard of care alone in this particular trial. All right, so how did this work? Well, the ExoSomeDx arm had 458 patients versus the control arm and had 484, very similar. Okay, ExoSomeDx was collected on both, but only one arm of this, as you will see, shared this decision process of the ExoSomeDx score process before doing the biopsy with the patient. The standard of care arm had the ExoSomeDx collected, but those results were not given to potentially make a biopsy decision. It was just a standard of care decision making, okay? And we collected all these biopsy results, and the patients were followed up to 5 years. And this is the demographics, all right? And what's interesting here, and I want to emphasize, is unlike other studies, the African-American population in this particular trial was 23%. It was a little higher than most of these trials have looked at. And what's also interesting, when you look at the supplement in this particular paper, was that over 92% of those African-American patients had an EPI score over 15.6, all right? Which, ethnicity is an issue, okay? So let's look at the study flow. See if I can do this with the, so the urines collected, case report form, epi questionnaire informed consent is obtained. We perform the epi score. The subjects are randomized into an epi arm and a control arm. And what does that mean? Only epi arm received the results. No one was notified in advance if they were going to receive the epi result. And then the epi arm, the urologist received the test results for review with the patient during the final evaluation prior to biopsy. The control arm, okay, the urologist received notification of no epi result and continued biopsy discussion per standard of care, okay? And whether you had the epi results or you didn't have the epi results, patients were permitted to be told by the urologist should they get a biopsy or should they not get a biopsy on the questionnaire. So the decision tree, and this is basically just, the EPI score, this is on the decision tree of the people who received the EPI score. As you can see at the top here, 458 patients received this EPI result, of which 93 of these, or 20%, had an EPI score less than 15.6, okay? Of these, 63% were referred for deferral, okay? And out of that deferral, 92% followed their urologist advice. What's interesting, again, I just want you to be aware, is that still 37%, okay, of urologists recommended a biopsy, okay, even with an EPI score of 15.6. So I thought that was interesting because when we reviewed this, remember that all the patients who came into this trial were already recommended for a biopsy, but now we have a test that says, geez, maybe you don't have to worry about that biopsy. So why was this biopsy performed? And when I went into further research on this, basically these patients that might have been referred for a biopsy, even with a low risk epi score, it was a rapidly rising PSA. There was a strong family history, ethnicity. There was a nodule, suspicious digital rectal exam, age, meaning I assume in this case they were just very young, and some were just not answered. But I think it's interesting that there were still some biopsies that were recommended. You know, I think it's, you know, it's easy to say, right? The score is less than 15.6, but they're 52 and they have a PSA of 6. I think a lot of urologists would still go ahead with biopsy. Okay. Now, having said that, if these patients had a negative biopsy and they were 53, okay, the following year and their PSA was still 6, you know, I might use this test to prevent a second biopsy. And I think it's a little easier when you've had one biopsy and they're young and you go to the next year or the next 2 years and their PSA remains high to try to prevent a second biopsy. So I do think that that is an interesting way of looking at these things. Now, number 5, the remaining 37%, we talked about that. Number 6, 44% ultimately decided to defer biopsy. So out of the patients that were recommended for deferral, 92% had a compliance listening to the physician. Okay, when you look at the biopsy on the right side of this picture, all right, you can see that 80% of the patients had an epi score greater than 15.6, of which the physician, the urologist, recommend biopsy in 87% of these patients. Okay, of which 72%, okay, went ahead with it. All right, I think again, it's very. I think it's a lot user friendly to say to a patient, geez, we just did a test and you don't need a biopsy. I think the compliance is going to be a lot higher with patients who are told they don't need a biopsy than, you know, to tell a patient, you know, we do have to proceed with this biopsy. So I think the compliance is going to be a little less when you have to go with the biopsy. But as you can see here, there is a 72% compliance of what the urologist suggested and where patients went. Okay. This is kind of a busy slide, and I hope I said that appropriately because I had to look at this for quite a while. Now, this is, again, another busy slide, but I just want to go over the important aspects here. In a nutshell, we have an epi score on the bottom here, again, below 15.6 versus above 15.6, and in some cases, below or above 20. What you can see here is this orange or yellow line. That's basically a 39% control arm biopsy. That's basically, you know, the standard of care biopsy percentage. What's interesting about with the epi arm and the control arm in this particular trial is, again, you know, most of the studies done with other tests have suggested there's a diminished biopsy rate when we use these new tests, and I do agree with that. But what I do like about this trial, with it being blinded, is yes, if you look at this blue line, you do have a reduction in prostate biopsies compared to the control arm with a epi score of less than 15.6. But in addition, it doesn't necessarily mean you're going to have a reduced biopsy arm in the greater than 15.6, because in effect, you are actually going to have a higher percentage of biopsies performed on the higher epi scores, and you're going to be finding a higher incidence of high-grade prostate cancers. So this particular test and this particular trial and this particular graph here has suggested we're reducing the amount of biopsies in the patients that don't need it, thus the negative predictive value of 92 to 97%. But we are going to be biopsying the correct patients above that value that really do need to be biopsied, okay? And depending on what trial you look at, that percentage can be anywhere from 30 to 39% in the control arm, all the way up to 50 or 60% of high grades that you potentially need to find, and you can use this test to find them. Remember, the sensitivity is very high in this particular test, okay? So they are there, you just need to find them, and this test is going to help you find that. So I do like the exosome area under the curve in this clinical utility test, because although this is not exactly comparing apples to apples, but when you look at the area under the curve for the first validation trial of the JAM Oncology versus the European trial versus this clinical utility trial, all right, you can see that the area under the curve in this clinical utility trial, which is not at all like the validation trials, but you can see that the area under the curve for the epi score is very similar at 0.69 compared to the 0.7 and 0.71 of your validation trials. So real time equals validation trials. And I think that is extremely important. Okay, I love this trial. It's being, we're trying to get it presented at our New England meeting, if we have a meeting. We don't know that yet. So what are some of the key findings in the study? Well, when we implemented the ExoDx Prostate test in real world, it demonstrated an improved compliance with the patient's recommendation to defer prostate biopsy. And 68% of all physician recommendations using this test, whether a low score or a high score, was followed by the patient. And if the test was below 15.6, we had a reduction in biopsies, and there was a 92% compliance with that reduction, okay, versus a test above 15.6, okay, where we've actually found 58% of biopsies were performed, okay, and we found 30% more high-grade prostate cancers, all right. And when you look at this, there was a 49% fewer high-grade prostate cancers missed due to deferrals compared to the standard of care. And I think if you projected out the control arm, you're probably going to find or miss 90 to 95 high-grade prostate cancers in that standard of care arm. So standard of care is important. And as I stated to you in that clinical trial that I just went through, it's still important when it comes to determining who might need a prostate biopsy, even with a score that might be low, but we are still using that. The important aspect here is this is a standalone test without using standard of care to get you a numerical value that I think physicians can rely on a little easier than some of the other tests that are out there, okay? So what does the at-home test mean? Now, I don't know about the people out there that are listening to this, but I've had trouble getting patients into the office. You know, I've had trouble getting patients into the office to get PSAs, to get tests performed. So what am I doing with these patients that I need to figure out, Jesus, do they have prostate cancer? Is it a bad prostate cancer? I can't get them into the office. There is now, EXOSOME can be performed in, the test can be sent to the patient's office. I do a telemedicine. I say, your PSA is still high. I need to get this test. And the company has been very good. I think I was told I'm #1 now in the country, coming from a little state of Mass, but I have found this test to be very useful. It goes to the patient, they do the test. I again recommend to them how to hold that thing so it doesn't go in their shoe, and it's sent back on FedEx, okay? This has been extremely important, and I'm sort of using Dr. Judd Mile here because he at Duke is also using this, and he's using these scores. Anything, you know, cut point below 15.6, if that exosome comes back, you know, you can safely defer and not have patients come in immediately. 15.6 to 20.5, I'm not sure there's much of a difference there, but you can prioritize trying to get patients in a little sooner because it is above the 15.6. But again, if the epi score is above 30 to 50, again, you know, that binary, if they have a score of 50 or above, you know, they have a high likelihood of 60 or above of having a high-grade prostate cancer, and I think you need to get those patients in for an immediate biopsy, all right? You need to prioritize how these patients are going to come in. Now, I don't know how long this COVID issue is going to go on. I think it's going to be an issue in my state because we just started phase 1, and our governor is extremely cautious, as maybe he should be, but at each one of these phases from 1 to 4 is potentially going to take 3 weeks. So we may be out there doing telemedicine visits for quite some time. And honestly, I'm a little nervous. And why am I nervous? So I put this slide together. You know, the AUA daily scope, I don't know who looks at that, not a very scientific measurement, but has suggested that over 80,000 diagnoses of 5 common cancers, which are lung, cervical, colorectal, breast, and prostate, may be missed or delayed because of this disruption of this COVID pandemic, of which out of the prostate cancer, we may be missing, you know, 22,600,000 cases, all right, 22,000 cases. In addition, what I did like in this article was patients who had cancers and had the COVID had a higher fatality rate. So obviously people with comorbid conditions, not just lung, and not just, you know, bad, you know, but even lung cancer or any other cancer can have an issue with this. So when I was online, because I'm on the surgical committees at both my hospitals, you know, we're now in the process of when we open up, you know, for elective cases in the operating room, we have to we have to grade them, immediate versus, intermediate versus we can wait on these. But, when I ask questions about, well, what if we missed, cancers, or what if patients get upset with us for waiting too long? I actually found out that urologists are not totally indemnified from patient prosecution concerning our decision making to perform urgent or elective procedures such as prostate biopsies. So waiting to be biopsied or missing a high-grade prostate cancer is going to stress myself as well as the patient. So I think this Exosome DX excuse me, can be very helpful in prioritizing a correct diagnosis and treatment and avoid incorrect care and potential legal issues. We are not totally indemnified, I found out. So I think you need to use this test to help with the fear of missing something, both from a patient standpoint as well as urologist. So I would strongly recommend that you consider using this test to send home if you're in a state that's in that position that you need to do this, which is mine, and consider it. Now, this is the exosome report. Very easy to look at. I kind of, I like the score system here. As you can see to the left, the cut point is here. Below that is green, the negative predictive value of 92%, and above that is the sensitivity of 92% of finding high grade. Okay, it's very easy to figure out. They have an arrow. There's a cut point. And again, that cut point can change. I just want to emphasize, if you use this test a lot, that cut point can change. So that cut point can go closer to 29 or 30 if they've had a repeat biopsy. That's the way I use this test, okay? Because I do think, the negative predictive value will go up if you've already had a negative biopsy. To the right, you can get a more aggressive interpretation of the score, okay, if you're not familiar with this test, okay? And again, this is the binary epi scores, where the score 10 up to 60 is pretty much 10 to 60% of high-grade prostate cancers being found. Okay, this is a pooled analysis of over 1,000 patients when we looked at this in the European Association of Urology. Now, what about those 3 initial patients that I talked about at the beginning of this? Well, what's interesting is that they all had the same age, all had the same PSA, but the epi scores are extremely high on patient. Why do we have D, E, and F? It's the first time I've noticed that. Okay, so E and F had high scores and were found to have Gleason 8 and a Gleason 7, 4 plus 3. All patients were biopsied. What's interesting is patient D here was the African American, and he had the low epi score. All right, now having said that, there may be a urologist out there that may have had a low epi score, and because of that African American, had a biopsy for that reason. Okay, so again, standard of care is still being looked at, as it should be. Okay, so that test, all right, the Exosome DX test was very useful in determining who had cancer and who had high-grade cancer, most importantly. So this Exosome DX INTELLISCORE test recap. It's a random urine, no digital rectal exam. It's a test based with a PSA within the 2 to 10 range for a patient over 50 years of age. All right. All the clinical data was strictly with the 2 to 10. It was not higher than some of the other companies that are using 20, 30, and 40. The 3-gene molecular RNA was looked at, as I stated, the URG, the PCA3, and the SPRDF. Only test that does not consider standard of care parameters in their algorithm. Okay, that's not to say that we don't use a standard of care to help make this decision making, but it is not within that test itself. It's completely non-invasive. It's as we stated, a liquid biopsy test. It's simple. All right, it's simple for the patient. It's simple for me. It's a non-digital rectal. You have to incorporate this a little differently because we do rectal exams usually in my beginning when I was using this before I ordered the test. But as I stated, you can now do this at home, which makes this a lot easier. Again, only 15 cc's and within an hour of urinating issues. In summary, non-digital rectal exam, liquid biopsy. Again, I just went through the greater than 50, 2 to 10 only. The strong relevant clinical validation data, clinical utility, study data, and publications have validated this great test, I think, and you can avoid 30% or more of unnecessary prostate biopsies, which I do think is important with the negative predictive value of this test, but at the same time, if you remember that one graph, it is picking up high-grade cancers above the value, which I think is just as important. So when you see competing companies say they did a clinical utility trial and it's reduced the amount of prostate biopsies, that's great for the negative predictive value where you're not going to find the cancers, but you still are going to need to find that high-grade cancers above a certain value, and I think that's just as important. It's in the guidelines, as I stated. Relevant publications, my thank you slide, and my second thank you slide. And that's my story, and I'm sticking to it.
Very good, Dr. Hurley. Thank you so much. We had a really great attendance for the full hour. That was robust with so much information. And we did have several questions come in, and I'll go ahead and read them and remind everyone that questions can be entered in the question box or the chat box. So one of the questions was, why are there no clinical parameters included in the algorithm? And I'll also say Jason Alter, our head of clinical affairs, is on the line also if you want support on that question.
Well, there's no clinical parameters because this is a standalone test. You don't need standard of care clinical parameters. So you don't need that. And if you remember one of those slides with the area under the curve where I looked at the EpiScore plus standard of care versus the EpiScore alone, there was really no advantage using the standard of care as a clinical parameter and giving you a score using this EpiScore. Okay, so the strength here is you don't need clinical parameters when the score for Epi comes out. Now, that's, again, I do want to emphasize, that's not to say that you're not going to be using standard of care in some of your biopsy decisions, because that clinical utility trial, obviously there was still some people, all right, who had a reduced Epi score of less than 15.6 who still had a biopsy, all right? So there was something in that standard of care or clinical parameters that required them to do a biopsy. And as I stated, if you had a 52-year-old, and I'll be honest, even with the company here, if I have a 52-year-old with a PSA of 6, I'm going to do a biopsy, whether the Epi score is low or not. So I think a lot of urologists would do the same thing. Again, I would probably use that young patient, if he had a negative biopsy, to use the Epi score even more appropriately for a negative biopsy the following year if their PSA remains high. But you still use a standard of care, it's just not part of the scoring of this particular test.
Great. And another question, one of the outcomes that was found in the clinical utility study indicated that Epi influences patient compliance to the physician recommendation. Do you find that in your own practice?
Yeah, you know, this test is unusually good because, you know, as I stated, you know, probably up to 60% of the people in the control arm, which is the standard of care, didn't want a biopsy. Now remember, all the patients going into this clinical utility trial were thought of needing a biopsy. So 60% really didn't want a biopsy, okay? Even after the urologist said, well, you know, it's this, that. I think this particular test helps you and helps you, you know, allay the fears of the urologist and the patient to say, listen, your Epi score is higher than 15.6. I think it is something that we need to consider. And if you can state to them that, you know, only 9% of cancers are missed, you know, high-grade cancers below this 15.6, and that you're finding a lot more cancers above this 15.6. As I stated to you, there was a 92% compliance of following the urologist's decision-making using this Epi score and their standard of care parameters when they talked to the patient about no biopsy versus, you know, I think it was 72% compliance with getting a biopsy if the Epi score was above 15.6. So, you know, again, I want to emphasize, I think it's a lot easier to talk a patient into not having a biopsy than to have a biopsy. So you're going to see a compliance rate a little higher, you know, talking them out of a biopsy. But I think it does influence, you know, how your group is looking at these things. And I think practice patterns are influenced by these study designs. So I do think it's important to consider that.
Great. And another question here, since you've had so much experience with the at-home collection kit, can you weigh in a little bit on the experience on behalf of your patients?
Oh, geez. Well, first of all, the company has done such a great job in marketing this and getting it to the patient's office. And, between Carla here and Catherine. They've been very helpful with my nurse and secretary, getting this thing to the office. It goes straight to the office with detailed instructions. And I will tell you on the telemed, I do instruct them on how to do this test. And again, because they're more worried, I'm more worried about their shoes getting wet, but it's a simple test. It's only 15 cc's, but you have to stress to them that they have to wait an hour in between voiding, because this trial also, which is interesting, is there was a 5 to 7% assay failure, and if you don't get this urine correctly, and there's not enough of these markers, to be filtered, you're going to get a insufficient quantity type result. So you need to do this appropriately, which is you have to at least wait an hour between collection, and you only need the first 15 cc's. So it goes to them, they do it, they send it back with FedEx, and I call them within a week with the results. And it's interesting, of the 10 or 15 I've done, the majority have been below the epi score, and they're extremely happy when I say to them, listen, I don't think we have to worry right now. You don't have to come into the office. I mean, I do like still doing my digital rectal exams to make sure I'm not missing anything, as 15 and 20% of cancers are still found that way. But it's nice that they feel better and I feel better by doing this test. So it is extremely easy. And if you have any issues, you could call me, and I can have my nurse talk to your nurse. But the company's been very informative on how to do this.
Great, thank you. And another question came in: why is a DRE not needed?
Well, I actually asked that too. It's funny whoever asked that, because honestly, the standard of care is not part of this. So that's one reason. Secondly, if there's a digital rectal done and there is a nodule, you're probably going to do a biopsy, right? So I think they were looking at parameters of PSA alone versus anything else that might correlate with a biopsy definitively, because whether your PSA is 2 and whether your epi score is 15.6 or less, if you have a nodule, you're still going to do a biopsy. So I think they threw that parameter out just because I think they were looking at the more common scenarios, which is a PSA grade of 2 to 10 versus anything else, and that's why the standard of care is not part of the score.
Fantastic. Okay, I'm not seeing any other questions here, so I would like to ask you just one last one, Dr. Hurley. If someone wanted to contact you after the program, do you want to provide an email address or a way to contact you?
Yeah, so very easy. Hurley, LHURLEY 3544 @gmail.com. Happy to help. Nobody asked this question, but I will tell you that we're doing MRIs now, and as you know, MRIs is only as good as the people reading them. Some of the sensitivity is not that good with some of the people reading them, but I will suggest to you that although Exosome DX only misses probably 6% of high-grade prostate cancers, if they're combined with a potential positive MRI of PIRAT 4 or 5, and the exosome is positive, you're probably going to miss only 0 high-grade prostate cancer. So, if they are in concordance, you're going to need the biopsy, and no high grades will be missed if you use those two tests together. Because occasionally, I'm not sure I can trust my MRIs if my exosome is high, okay, and they've had a repeat biopsy in the past, and for instance, a confirmed MDX suggests that there's epigenetic change somewhere in that prostate. I might do a fusion area using an exosome score in the area that had the confirmed MDX. So I do think using MRIs with these biomarkers is going to be a thing of the future. So I think it is something you should consider, because if you're lucky enough to be in an academic institution that has great radiologists reading these things, so much the better. But I still think we have a long way to go with these MRI readings in the community setting where I am. So I would use these biomarkers to help you decide what you need to do with these patients.
That's great, and that's great data that we saw at ASCO GU this year with the EPI combined with MRI data. So thanks for reminding us of that. So with that, thank you, Dr. Hurley, for a fantastic talk. This will be recorded and happy to share it within a week of the program. And with that, we'll go ahead and end. Thank you.
Thank you.